exams, which is the rule of compensation. Uh, CO2 and bicarb, we all know they are moving in the same direction to compensate each other. But the rate can be predicted by this formula. And I have this photo from AGKD, which you can have this wonderful paper on the internet. And you must know a golden and high yield phase, which is if the compensation is not adequate or more than expected, this is a mixed disorder for 100%. If you calculated the expected CO2 or the expected bicarb and it is not adequate or more than expected, it's a mixed disorder. So when we can go to the next slide about the urine anion gap. When I should measure the urine anion gap, if in the case I have measured the delta ratio and the ABG shows that it is normal anion gap metabolic acidosis, I repeat again, it is normal anion gap metabolic acidosis. So I should for sure measure the urine anion gap, which is sodium plus potassium minus chloride. And we have two way here. It is a positive or negative. If it is a positive urine anion gap, then it should suggest low NH4, which is going to the diagnosis of renal tubular acidosis. And if it is negative, it suggests something called for diarrhea, and I have gives a table to differentiate between the two, if it's a positive or a negative. And if you are giving in the question the urinary pH, then he guide you to answer the question of the renal tubular acidosis type. If the urinary pH is more than 6, it is type 1. If it's below 5.5, it is a type 2 or type 4 renal tubular acidosis. And another note from me, you can differentiate between type 2 and 4 by potassium. The presence of hyperkalemia is suggestive of type 4 renal tubular acidosis. So let's go to the last thing. The last thing is called osmolar gap. Here we can measure the osmolar gap by measuring the osmolarity and minus it from the calculated osmolarity. Calculated osmolarity is 2 of sodium plus glucose plus urea, and then minus by the measured osmolarity on the question. I have a note, which is a very simple note. If he give you the measured osmolarity in the vignette, please measure the osmolar gap. Don't don't assume he give you something for the sake of time. No, everything is measured. They give you the measured osmolarity in the vignette to calculate the osmolarity and measure the osmolar gap. And if it is high more than 10, it is something abnormal and which is related 100% to ethanol, and it is always about alcohol toxicity in examination. So I have here three questions which came with another type of examination before about differential diagnosis. If a case come with high anion gap metabolic acidosis with high osmolar gap, what will be your differential diagnosis? First of all, your answer must be systematic, not haphazard, not gunshot answering. You must say there is a metabolic causes like blah blah blah. There is toxins like blah 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 blah. Don't say DKA, lactic acidosis, methanol. You must be systematic. And there is a question happened here also about exogenous substance are related to increased osmolar gap, which we have here. It's always related to alcohol. And there is also non-toxical substance related with increased osmolar gap, which here have chronic renal failure, DKA, hyperlipidemia, and you will can take a screenshot, or we can send you the PDF of this lecture on the group. You will have all the answers. So that's all. Like I said, it's not teachable 100%. It's a practical. We can practice a lot, and in this way, we can find ABG more easy. And I always advise my fellow to practice bedside. Bedside, the patient is always important more than the laptop or on the mobile. So I can see Carolina because I'm on the full screen. Can you see me? Can you hear me? Hello?
Yes, yes. We can hear you. Dr. Kirlos, we
Okay.
can hear you. You have finished? Okay, perfect. So thank you, Dr. Kirlos, for this excellent ABG discussion. And also it has actually covered the whole the concept and the approach how to like read the ABG in the exam at the bedside, and that would be really helpful. So any questions or else I would be starting
I can have
the
here
last section.
some cases. Hello,
Yes,
Dr.
please
Tapas. I
continue.
have here
Yes,
some
yes,
cases we can
yes,
practice
yes.
with each.
Yeah, yeah, please.
So uh, I can share the slide. Okay. Let's remember again the deathly hallows. Please be aware of the time, be aware to read the vignette, and to find the study part. Let's begin with the first case. I can see the. Okay. Anyone could answer this question?
Your slide is not moving. Is it moving?
This is the question. Are you seeing it?
No, we are unable to see the question. The
Okay,
slide
let's
is
start
stuck. Yeah, yeah.
and start sharing again. Windows, PowerPoint. You see it now?
No, your screen is not shared now.
Okay.
Do you want us to share the screen for you?
Okay. I share the screen, but
Okay, it's not
it's
showing
not
to us.
visible.
Okay, Bhagyasri, just 1 second.
Yes, sir.
Okay, I
Yeah, can you share the screen of Dr. Kirlo's presentation on the slide from where like no he
Yes.
had stopped?
Please let me know the slide number.
okay. Slide number
You can share with me,
50.
Doctor. Yeah, I would be sharing,
Slide
no
number
problem.
50. Yeah,
50. Okay,
15. Yeah.
15. Okay.
So can I share the screen?
Yes, yes, please.
Okay, sir. So is my screen visible?
It is about to. Yeah. Go to the 15 number slide. Yes, perfect. You can make the zoom.
Yes, sir.
Okay. Uh,
Excellent.
will be our first case.
Yes.
have the chat. Anyone could answer this question, but please stick to the vignette, as I said, and please be aware of time. This is a 51 years old patient intubated for 3 days of pneumonia. He is on furosemide infusion, and please, if any drug are mentioned in the vignette, be aware of it. And small doses of noradrenaline. Here, the sodium is high and potassium is low. Chloride is normal. Potassium is normal. Glucose is borderline normal high. Urea is normal. Creat is high. Albumin is 18. pH is high, is not hypoxemia. CO2 is high. Bicarb is too high. And what would be your answer for this question? Next slide, please.
Bhagyasri, next
And we
slide,
have
please. Bhagyasri, can you move to the next slide?
can you see my screen?
Yeah. It is now. We can see. Yeah.
Okay, that is good. Yeah, so
No, it is again disconnected.
again, why?
It is happening, something
I
happening.
think when I go to the slideshow, it disappear. You see it like this?
No problem. I am sharing right now. Don't worry. Okay, just open. These are the things that normally happen in the exam. So don't worry. We have to troubleshoot it also. No worries. Uh,
You are not seeing right now.
just 1 second. I am just sharing the screen. Yeah, your screen is now visible. You can make it in the Zoom, or else you can continue in this format. No problem. Okay, you can continue. Yeah.
When I click slide,
No,
it
no, you don't do.
disappears.
No, don't do the slide presentation. You continue like this. Okay, perfect.
Okay. So the answer here would be it is a metabolic acidosis. When I look to the BDH, it is high. The bicarb is also high. So it is going to the same way. It is a metabolic, the metabolic acid alkalosis. And when I look to the sodium, it is hypernatremia and hypokalemia, which is going for a chronic diuretic use. So in every exam, they will not ask you about what is happening. They will ask you what is the next step. It's always, I am tell you, the next step. And they need a focused answers like stop furosemide, deliver free water in nasogastric tube, its preferred route. These answers are of important value for the examiner. So you must have awareness of the time of examination. Let's go to the next question. And I really want to see your answers. The question say, you see a patient with nausea, abdominal pain, and non-resolving acidosis admitted with DKA 2 days ago. He has been on IV insulin, and there is hypokalemia, there is hypercholesterolemia, the glucose is high, and there is albumin is mentioned. The pH is low, and the CO2 is also low. So what will be our thinking? And the bicarb also is low. So the question is, what is the explanation for these symptoms and how would you manage it? Let's go to the answers. When we have a metabolic acidosis, like I said before, I must calculate the anion gap. And here the anion gap is by calculation. have the sodium, we have the potassium, we have the chloride, and we have the bicarbonate, which turn out to be two. Two here is low and normal, so it is normal ion gap metabolic acidosis. And if we have to measure the delta ion gap, it will be lower than zero point 0.4, and it direct us to the hyperchloremic metabolic acidosis of the normal ion gap metabolic acidosis. Why this happen here? It's because the chloride overload of the normal saline which I have given to the patient in the DKA, which make the acid-base disorder mentioned in this question. So my answers will be, what is the explanation? It is a normal ion gap metabolic acidosis due to chloride overload of the of the normal saline use. And how would you manage it? I will stop it and uh, replace the potassium first before the insulin. And the explanation for this case is a large volume of the normal saline during DKA make chloride load, and this bicarbonate make a bicarbonate dilution and renal bicarbonate loss and make the patient go to metabolic acidosis. We have here two tables of causes of high anion gap metabolic acidosis and the causes of the normal anion gap metabolic acidosis. I can give here a big note. It must be read and memorize it for every exam. The causes of the high anion gap and the normal anion gap is a lot of importance for examination. Let's go to the next case. We have here a 52 years old obese man with advanced COPD presented with exacerbation, dyspneic, but not in extreme. Glasgow scale is 14. Look at this ABG and describe the acid-base abnormality and why is the chloride is so low. Let's see the chat box. Okay, let's go to answers. Like I told you, the pH is low and the CO2 is high. They are in the opposite direction. So it is a respiratory acid disorder. In this case, it is a respiratory acidosis. So I think about what is if acute or chronic or acute on top of chronic. The right answer of this question, which a lot of intensivists lose mark, they didn't define the phase of this respiratory acidosis. This and acute on top of chronic respiratory acidosis, like this table gives us guidance. And the hypochloremia, it is because the renal compensation of chronic CO2 retention of the COPD patient involve increase the bicarbonate reabsorption in exchange for chloride loss. So the chloride loss in the opposite side, there is a reabsorption of bicarbonate. So the hypochloremia reflects the renal adaptation, not a separate metabolic alkalosis. So as a simple acid Z, chloride is low due to high bicarbonate. And this type of answers they need from you in the examination to be as fast as possible to get the mark full. Let's go to the next slide. Be aware of this question. It happened a lot in examination. It is a 27 years old man admitted with rectal bleeding due to hemorrhoids to the surgical ward. His blood count were normal. Soon after ligation of the hemorrhoids, he became febrile, tachypneic, confused. CBC shows that white blood cells, which is an arrow of red, tell you that it is 110, and the pH is low. The BO2 is 52 millimeter, and there's electrolyte and show you that the pulse oximetry that the SpO2 is 96. So what is happening here in this case? You must have a spotty eye for the key of all questions. Here you have hypoxemia in the arterial system, but the pulse oximetry show normal saturation. This has a coloration. Let's go to the answers. This is something called, and it is a high yield for examination called pseudo hypoxemia, which is leukocyte latency. Let's break it down. So note that there is hypoxemia in the blood, but the pulse oximetry is normal. This discrepancy occur in leukemia. This is called pseudo hypoxemia. The simplest explanation is that increased in blood cells, which is white blood cells, consume a lot of oxygen cells. The blood is low, Ba2 is low, but the plasma BO2 is normal in such case. Please also note the potassium here is 6, which may be due to acidosis, due to extracellular shift of potassium, or pseudo hyperkalemia, which is occur in raised blood count, which we have here the white blood cells. So let's go to the next question. A 30 years old man presents with fever, vomiting, sweating, confusion, and agitation. The following values are measured on the arterial blood, describe the acid base status, and name two possible diagnoses. And I repeat, here the pH is normal. Let's go to the answer. This is a triple acid disorder. How I know it is triple acids? Let's go to the last of the answers. It is a salicylate toxicity. Here, there is pH of 7.4, PCO2 of 25, and the bicarbonate is 50. I assume that it is a metabolic acidosis, so I calculate the anion gap, which here is 20, and the 20 here is high. So it is a patient with a high anion gap metabolic acidosis. In high anion gap metabolic acidosis, I must calculate the delta ratio. Delta ratio here, it is more than 2. So it is there is another acid base disorder compromising the high iron gap metabolic acidosis, which is high iron gap metabolic acidosis with pre-existent respiratory alkalosis. Why this happen in salicylate toxicity? It's because salicylate directly stimulates the respiratory center in the brainstem, causing primary respiratory alkalosis and also cause a high anion gap metabolic acidosis by uncoupling oxidative phosphorylation, leading to lactic acidosis. So it is a mixed type of acid-base disorder. And here we have the explanation of the book. I think it's the same. And I am always telling my friend in examination, they are focusing more on mixed disorder. It is not about only the single primary disorder. Let's go to the next slide. And I think it is too easy. You see it, or I can zoom. A 40 years old man is pulled from a house fire and brought to the emergency department in the early hours of the morning, and the paramedic estimate he is likely to have been trapped in smoke-filled room for about 20 minutes. The examination of the patient is heavily contaminated with tooth and smells strongly of smoke. Fortunately, he has sustained any thermal injury. He appeared to be confused and has just vomited. Baseline observation are normal with an oxygen and saturation of 99% of 15-liter oxygen mask. And here we have the labs. Be aware of something really high yield. When you see the labs here, and you spotted cardiac monoxide assay, which here calling for 40, and the slide here gives you that non-smoker it is okay for below than 3, and in a smoker it is okay below than 10. So I think we all have the answer, which is carbon monoxide poisoning. So uh, why this patient is hypoxemic? Because carbon monoxide bind to hemoglobin 200 times the affinity of the normal oxygen, and therefore it is carried on the hemoglobin molecules in preference to oxygen. So, as a consequence, the percentage of hemoglobin saturation with oxygen is markedly reduced in carbon monoxide poisoning. So, there is not a question here going to what is the next step. If you don't tell the examiner what is the next step, it's not you give him we can admit it as ICU and blah blah blah, and never said apply oxygen to the patient. It's a fatal mistake. Oxygen is of a priority here in this case. Don't forget about the oxygen. Let's go to the next slide. I think this is the last slide. 36 years old man admitted to the ER in the middle of the night, complaining of vomiting, malaise, visual problems, and shortness of breath. The patient respiratory rate is 32 and chest is clear on auscultation. The investigation show he gave me electrolyte and he gave me an ABG, and he told me that the measured serum osmolarity was 45. And I told you before, if he give you a measured serum osmolarity, you must calculate what we will know in the answer. While the patient was being treated, 16 more patients with a similar history were admitted to the ER. All gave the same history of drinking cheap country liquor for a local outlet. What will be your diagnosis? I think we all have the diagnosis, which is always related to alcohol. But how we can answer this question? I give this question to know the approach, how to answer this question. We have pH here is low, and the CO2 is low, so it is a metabolic disorder. The bicarb here is low, so it is a metabolic acidosis. So I can measure the anion gap. Here, the anion gap is 23, which is high anion gap metabolic acidosis. And when I calculate the delta ratio, it gives me 1.3, which suggests of uncomplicated high anion gap metabolic acidosis. So when he give me serum osmolarity, I must calculate the osmolar gap. When I calculated the osmolar gap, it is too high. It is 140, and here the osmolar gap is increased more than 10. There is no other obvious cause of increased other gas other than methanol or ethanol toxicity. So this patient, when came to the ER, I must first of all ABCD, but not mentioning it, the antidote of alcohol toxicity, and must send for toxicology screen because it diagnosed with toxicology screen. And don't miss the if it is refractory to the medical treatment, you can initiate hemodialysis for the alcohol. Let's go to that is the last slide. Think here. Yeah, this is the last slide. A 55 years old male is admitted to the ER with suspicion of intoxication. He is confused on polypia on clinical examination. He has a central as well as peripheral cyanosis. His pulse oximeter reads 85 on oxygen 7 liter. The examination is otherwise normal. The patient has a history of eosinophilic cellulitis and alcohol abuse, and a prescription of Tapson is noted. Be aware of any drug mentioned in the vignette. He gave me an CBC and electrolyte and an ABG. So describe the most significant finding and what will be likely diagnosis. Okay, in the chat box, they answered right. Yes, it is methemoglobinemia. The hypoxemia on the pulse oximetry and the hyperoxia on the ABG. It is the most suggestive way of methemoglobinemia. Most important findings here we have lactic acidosis with respiratory compensation. The elevated CK also must be mentioned. I give this question to we all forget about the other pathologies in the cases. I must say there is high CK indicated rhabdomyolysis, and believe me, that is answer of their answer sheets of EDIC Part 2. I must say all the pathology. So, when I recap the APG lecture, this is the last question. You must practice a lot. So, thank you very much for your time, and I hope I give a helpful lecture. And again, excuse me for my English, it's not my first language. And you can contact me anytime on WhatsApp. Feel free anytime, and you can join my WhatsApp channel for any question you have, particularly for EDIC Part 2. And if I have an advice for this lecture, I only give this to all my uh, candidates for exam. Be aware of time, read the vignette, it has 100% of the answer, and find a positive study partner. Thank you all, and I wish to have another lecture another time.
Thank you, Dr. Kirlos. If you can stop sharing, then I can start sharing my screen. And in the meantime, there is a question in the chat box about what is the importance of base access. So I would be taking the question if you don't mind, Dr. Kirlos.
Okay.
Okay, so base excess is actually the metabolic component of any acid-base balance, independent of PaCO2. So here PaCO2 is not important when we are discussing about base excess. Now base excess less than -2. This is metabolic acidosis. That is base deficit. It is not base excess now. Now if base excess is more than +2, it is metabolic alkalosis. That means excess base is there. Now this reflects the severity of the metabolic disturbance better than pH alone. So when we have base excess along with the pH, so that would be guiding us whether we are dealing with the severe form of metabolic acidosis or alkalosis. Now this is useful in shock, sepsis, decay when we are dealing with diabetic ketoacidosis, and trauma to assess the global metabolic stress. So remember these words. If the examiner asks you, you can use these words. That would be very impressive. Global metabolic stress. And this helps to track the response to the therapy, whether we are giving fluid, whether we are doing the RRT for the metabolic acidosis or the bicarbonate therapy. So always remember base excess changes are actually directly proportional to the metabolic problem, and PaCO2 changes would be towards the respiratory problem. I think I have tried to clear little bit of air around this base excess. So remember, -2 + 2, base excess, base deficit, global metabolic stress. Perfect. So if you all allow, so I would be taking you to the last lecture. Before that, Dr. Kirlos, once again, thank you from 360 Critical Care team for sharing your expertise to all of us. And hopefully this lecture would be beneficial to all the critical care trainees and the examinees. Now, last but not the least, the fourth lecture, and this is something once we enter into the ICU, the beep, the alarm on the ventilator, you would be trying to solve the problem with the ventilator graphics. So the topic title is when curves peak, we need to understand the ventilator graphics. This is one of the quote that I just found from the literature, that ventilator graphics are nothing, rather they are the signals coming out of the patient, going into the ventilator and pop up on the screen. This is by Warren Sanborn, and this is so appropriate in our day-to-day clinical practice. Now, why graphics? Why graphics are important? Graphics are waveforms that reflect the patient ventilator system and their interaction. Simple. So if the examiner asks you why we need ventilator graphics to the analyze and interpret and troubleshoot our patient's hemodynamics and also ventilatory requirement, so we need to be very thorough that the purpose of monitoring the graphics are to allow the users to interpret, number one, evaluate and troubleshoot the ventilator and the patient's response to the ventilator. It's not only the ventilator, how the patient is behaving to the ventilator, monitor the patient's disease status, the most important in the respiratory ICU or the patients on ventilator for the region of pneumonia or respiratory problem is the compliance and the resistance of the airway. Assess the patient's response to the therapy that we are using, whether it is bronchodilator, whether we are giving steroids, whether we are dehydrating by doing deresuscitation. So we all need to know with the graphics how it is actually affecting. Monitor the proper ventilator function, and finally allow the fine tuning of the ventilator to decrease the work of breathing, which is the utmost importance in our the clinical the area. Optimize the ventilation and maximize the patient comfort. That is our goal when we are deciding to put the patient on ventilator. Now, just a simple physics that I will be taking you into the next floor slides. How a breath is delivered. Simple. There would be the baseline PEEP, there would be inspiratory phase, then there would be expiratory phase. And you have seen here, time is in the x-axis, pressure is in the y-axis. Now, here comes the patient's trigger. Patient is trying to breathe, and that is initiating the inspiratory phase. So the blue mark is the trigger. So patient is trying to take the breath inside, and that is actually triggering the ventilator to give the breath. Now, the trigger has already been given. Now the patient is trying to take the breath, but till what time, till what volume, till what pressure, that would be depending on the target that we are fixing here. So the inspiratory phase will end when our target is fulfilled, whether it is volume or it is pressure. Now, once the target is achieved, then there would be a cycling phase. And the cycling phase would take our patient or the ventilator to the expiratory phase, and it would be again coming to the PEEP set PEEP level, and it will be continuing, and then there will be a new trigger, and the patient will be again taking to the inspiratory phase with the target and the cycling phase. Clear? So this is a basic idea how a breath is delivered. Now, what are the what are the types of waveforms? That would be something very important before going into the detailed analysis of the waveform. So the waveforms can be divided into scalars and loops. Scalars, they are actually plotting the pressure, the volume, and the flow against the time. And here time is the x-axis. That means pressure, volume, and flow will be in the y-axis. And this is one form of scalar. Clear? Now, loops are plot that pressure or flow against volume. So that means PV, FV. There is no time component in the loop. And this would be looking like this is flow time, flow volume. Clear? Now, so these are all the, like you would say, the pressure time, volume time, and the flow time. Clear? Now, can anybody tell me what is the mode here in this scalars that I have said here? Anyone? Yes, 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 perfect. So you all know, yes. So all these are basic things. The examiner may show you some of the prefixed the images, and they will be trying to get the answer from you, because in the exam it is not the time to go into the detail how these are actually formed or what are the basics, but I will try to give you a lot of pictures, images, so that your idea would be more robust before the exam. And these are the flow volume and the pressure volume, which are the loops. And you can see here in the flow volume, inspiration would be above the baseline and expiration would be below the baseline. So it would be, you can see inspiration and then expiration. And in the pressure volume, you see the exhalation goes up. There would be peak inspiratory pressure, and then the inhalation happens, and it would be again going in this direction. Clear? So this is the concept with which we should be going into the basic shapes of the waveform. And these are the basic shape of the waveform. The examiner may ask you, like, is there any other waveform you know shape apart from the square or the sine? So it is ascending ramp, descending ramp, sine wave, exponential rising, exponential decay. Clear? Now, what are the types of waveforms? If you will say like the square wave, it represents a constant or set parameter. If we have taken the pressure maximum to be 20, so it would be delivering till the pressure reaches 20. Now, the case with the ramp wave, it is a variable parameter. Like it will vary with the changes in the lung characteristics. It can be accelerating, it can be decelerating. And sine wave, it is seen with the spontaneous unsupported breaths like this. Clear? Now, if we are trying to differentiate between the volume mode and the pressure mode, I asked you the question 2 slides before. The volume mode, you will get the pressure wave scalar like this, flow scalar like this, and the volume scalar like this. This is volume control. In the examination, they will try to confuse you. So you have to be very sure. In the pressure mode, the characteristic feature would be the pressure scalar would be in the square form because it is set. And in the volume mode, the flow, the target would be square. Okay, these are the two things if you are getting. So you would be very sure that you are dealing with either a pressure mode or the volume mode. Concept clear? Now, we need to now fix the problem. But in case we don't able to fix the problem, so we will be just shooting the system. Please don't shoot the examiner. They are like no poor people, so they are just trying to assess you so that you become good intensivist. So at least you try to solve the problem so that they would be happy. So this is something with which we'll now proceed ahead with the pressure time waveform. Now the uses when we are dealing with pressure time, I have already shown you the scalars, air trapping, whether it is auto PP generating, airway obstruction, bronchodilator response, respiratory mechanics, compliance or resistance of the airway, active exhalation, breath type, whether it is pressure or the volume, peak inspiratory pressure, P plat, CPAP, PEEP, and asynchrony. So these are the uses with which we can like get the pressure time waveform in a proper way. And finally, the triggering effort, whether patient is able to trigger the ventilator. I have shown you, initiate the inspiratory phase. Now, pressure time waveform, what is happening here? Here, you can see the patient effort by the negative deflection here. Here, no patient effort, here patient effort. And you can see here the PEEP, the 5 here is the PEEP that is set. So PEEP is plus 5, patient effort is happening here, but in some of the ventilator breaths, they are not patient initiated or triggered. Now, this is the basic standard pressure time waveform. You should be very thorough. Now, if you start here, the begin the inspiration, here 1 is the peak inspiratory pressure, PEEP. Now, this part is the inspiratory, and you reach here at the end inspiratory pressure, the pressure which is named as plateau pressure, P plat. Now, here the A and B, here if you draw the line, the expiration happens here, and this is the expiration phase. Clear? Now, what is happening? The B here is the alveolar distending pressure. And that is the whole idea why we want the ARDS, low tidal volume ventilation with not distending the alveoli more than what is expected or that is required. So airway resistance would be the A part and B part is the alveolar distending pressure. Clear? So if it is rising, so you will be like labeling that whether the resistance part is actually affecting. But if it is affecting in the B part, you will say there is a compliance problem. Alveolar over distended. So you need to be reducing the PEEP so that we are not over distending the alveoli. Clear? Now, increased airway resistance due to n number of causes that we know. Increased, the kinking of the endotracheal tube, secretions, bite, maybe like anything that is affecting bronchospasm. So all these things would be increasing the peak inspiratory pressure. And this is the airway resistance. And the plateau pressure would be at the normal level. But if you are getting the compliance to be decreased in case of severe ARDS, your plateau pressure rises and anyway your peak inspiratory pressure would be the high, or it would be compensated with rise in the plateau pressure. That means the airway resistance will not be the problem here, rather it would be the plateau pressure. Clear? In the ARDS, you will get the plateau pressure to be high. Now, air trapping. Sometimes what happens if we are suspecting that auto PEEP is getting generated, we do the expiratory hold maneuver. In the examination, believe me, the DRNB examination on February 3rd and 4th, you are getting this and you remember me. How to do expiratory hold and what will be the utility of expiratory hold, how you would be deciding whether this patient is generating auto PEEP, what will be the total PEEP, and what would be the optimum PEEP, what is physiologic PEEP. So the examiner would be bombarding you with almost 7-8 questions on PEEP. So please clarify all the things with 1 or 2 lines because you will not get enough time to take 5 minutes of time for the PEEP only. So you have to be very crisp and answer to the point. Now here, when I'm doing the expiratory hold maneuver, I am getting the PEEP here, which is this is expiration is now almost in the plateau phase, and you are getting +9 here. So that is the auto PEEP. If you are not getting it, that means there is no auto PEEP. So your set PEEP is +5 and your auto PEEP is +9. So total PEEP is 9 plus 5, 14. Clear? Now coming to the pressure time waveform, if you are getting this type of waveforms in the pressure time, so what is happening here? You're actually the flow starvation happening. So flow is not adequate. So you have to increase the flow to reach to the expectation of the patient. Okay, otherwise there would be this flow starvation would be happening. This is like something scooping. Okay, now coming to the volume time waveform, what are the utility of the volume time waveform? This can be used to assess the air trapping. Again, we can get the air trapping auto PEEP. Leaks, that is most important here. knowing the tidal volume, active acceleration, and asynchrony. This is your something. Now you can see inspirated tidal volume is the maximum here. You are like inspiring here, reaching here. This is the maximum inspirated tidal volume. Now here you are beginning the expiration, and accelerated volume now returning to the baseline. So this is the volume time like waveform. Now, if the acceleration side of the waveform doesn't return to the baseline, it could be from air trapping or could be due to leak, like endotracheal tube leak, cuff leak, ventilator circuit leak, or if there is a chest drain, maybe the chest drain, there is some amount of leak happening in the chest drain. Now, that's why the waveform would look like it is going in the inspiratory phase, reaching the peak inspiratory volume, but in the expiration, what is happening? There is loss of volume here happening. And then again, your ventilator is giving the inspiration and it is reaching the peak inspiratory volume. So there is a definite loss of volume is happening here. And that is guiding you that you have to troubleshoot something so that there would be no loss of volume. Now coming to the flow time waveform. So flow time waveform would be looking like this in the pressure mode and in the volume mode. In the volume mode, it would be like the square wave, and the pressure wave, you will get this descending ramp pattern. Now, if you are getting the volume mode, this is the inspiration, and your expiration is happening from here. Clear? And in the pressure, it is a descending ramp. So you can see your inspiration and then expiration. Okay, so it is a constant flow happening in the volume, but in the pressure it is a decelerating flow. Now flow time waveform can be used to assess the air trapping, that is auto peep. So auto peep you can see in all the three: pressure time, volume time, and flow time. Airway obstruction, bronchodilator response, which is very good for like diagnosing and treating the bronchodilator in the flow time. Active exhalation, breath type, whether it is a pressure or volume, that I have already told you how you will be differentiating whether it is pressure generated or volume generated. Inspiratory flow, asynchrony, and triggering effort. Okay, now there are certain like troubleshooting that I would show you in the flow time. So now here what is happening? The inspiration, then expiration. Now expiration, the expiratory flow is not returning to the baseline here. That means it should go in this direction, but now it is going in the somehow it is going below. So that's why what will happen? So you will be getting a little bit of like the idea that it is actually not reaching to the baseline. It is taking a longer time here. So that means you are somehow stuck here, and the start of the next breath is happening from here. Okay. Now, if your patient is a COPD patient and you are getting the expiratory waveform, which is taking a long time, that means the adequate expiration is not happening, the acceleration is not happening, and there is dynamic hyperinflation happening. So the examiner would be expecting that you should say that the peak flow is not optimal, right? Pre-bronchodilator you see here, the peak flow is somehow here stuck, and it is taking a long expiratory time. Now, if your COPD patient you have started on nebulization, what is happening? Post bronchodilator, your peak flow is now getting shorter expiratory time because you are actually allowing the bronchospasm to be relieved with the bronchodilators. Clear? Now, coming to the loops, and the first loop is the pressure volume loop. Now, I have shown you the diagram of the pressure volume. The examiner may expect you to draw it in your exam. So just remember volume and pressure. So volume would be in the y-axis and pressure would be in the x-axis, and it would be like this. Okay. Now, so volume is on the y-axis, pressure is on the x-axis. Inspiratory curve is upward, expiratory curve is downward. So I have already told you. Clear? Inspiratory, expiratory. Okay. Now, spontaneous breaths go clockwise and positive pressure breaths go counterclockwise. So that is again one of the important things. So clockwise it would be spontaneous. You will be seeing it is a spontaneous breath. But positive press it will go anti-clockwise. Okay. Now the bottom of the loop will be at the set peep. So peep would be the first initiating point, and it will be 0 if you will be not putting any peep set. Now, if an imaginary line is drawn down the middle of the loop, the area to the right represents the inspiratory resistance, and area to the left represents the expiratory resistance. Now, by the pressure volume loop, what are the utility? They used to assess the lung overdistension, airway obstruction, bronchodilator response, respiratory mechanics, work of breathing, flow starvation, leaks, and triggering effort. Clear? Now, I have already like explained the theory part. Now looking at the picture. So this starts from like here, bottom is 5. Now here you can see here inspiration happening, and this patient is getting positive pressure, so it would be counterclockwise or anti-clockwise. Now if it would have been in the spontaneous part, then it would have been going in this direction, clockwise. Now here is the dynamic compliance. This is the joining point of the two inspiration and the expiration at the maximum level, and here the expiration happens. So it is just like you can see this is the counterclockwise, and you are putting a line here in the middle of this loop, and the right side would be inspiration, the left side would be the expiration. Clear? Now just think about if there is a beaking happening, just like bird's beak, that means you are actually over inflating to the your tidal volume what you have set. So that means you are actually trying to do some harm to the patient rather than any benefit. So you have to take care of low tidal volume so that there would not be volume trauma or villi trauma. Now coming to this pressure volume loop where you are getting some resistance, the troubleshooting, the problems. Now if you are getting increased expiratory resistance, it would be slightly swollen. You can see here it is all stressed to the expiratory part. Normally it should be in the black. You can see here. Sorry. So you can see here, like you would be looking at this would be, and this would be the normal thing. Now what is happening? If there is increased expiratory resistance because of the secretions, bronchospasm, it is getting stretch here, right? And now if you are getting increased inspiratory resistance, like king tube, patient biting, that means your inspiration is not affecting, like you are not like no being delivered in a proper way, so it is again getting stressed. Clear? So these are the basic things that you should be like doing it. Otherwise if in the examination they would be like expecting that you should be talking in a very lucid manner and again confidently, so that would be something you need to be very clear. Okay. Now, what is hysteresis? I have written in the middle of this loop hysteresis. The examiner are very fond of asking this question. So, hysteresis is the difference between inspiratory and expiratory limb of the pressure volume loop that I have shown you. Now, it reflects the energy loss during a breath due to alveolar recruitment or de-recruitment and tissue resistance. So, it's all related to the recruitment, de-recruitment, and tissue resistance. During inspiration, higher pressure is needed to open the collapsed alveoli. During expiration, alveoli remain open at the lower pressure so that you don't need to again and again reopen it. So, that's the idea of like avoiding the atelic trauma. Okay, so we need some amount of PEEP so that again and again we don't need to open it, and that would be more like damaging and releasing the cytokines. So the area within this loop represents the magnitude of the hysteresis. Now the clinical relevance, because we need to always correlate with clinical thing. So large hysteresis suggests unstable alveoli. Like if you are getting in the last picture, it is actually large hysteresis. The inspiratory part is actually distended. So that is unstable alveoli, ARDS, and that supports using adequate PEEP to minimize the cyclic collapse. Now, in this pressure volume loop, if you are getting towards the left side, that means increased compliance. And increased compliance example are emphysema, in the pediatric population, surfactant therapy. Now, in the decreased compliance, the inspiratory phase would be descending, or it would be towards the right side. That the most important thing for us is the ARDS CHF atelectasis. Now, if you are doing some maneuver and you are treating the patient in the low tidal volume ventilation with adequate PEEP, so maybe next day, 24 hour, 48 hour, you can see this one which is tilting towards like the right side, it would be going again towards the middle part in the center. So that means your treatment protocol is working. Now, coming to the flow volume loop, flow is plotted on the y-axis here and volume on the x-axis. Now, these are the loops which are used for same as like what we are using in the pulmonary function testing, PFT. So, ventilator graphics is equal to the pulmonary function test. Now, inspiration is above the horizontal line. I have already told. Expiration is below. And the shape of the inspiratory portion of the curve will match the flow waveform. I will be showing you all in the picture. Now the shape of the expiratory flow curve represents passive exhalation because there is no active thing happening. Since expiration is always passive. Now that can be used to determine the peak inspiratory force, peak expiratory force and tidal volume. And that would be somehow in the spontaneous breath, you will get the flow volume loop to be circular. Now that can be used to assess again the similar things that I have already discussed: air trapping, airway obstruction, airway resistance, bronchodilator response, inspiratory expiratory flow, flow starvation, leak, water or secretion accumulation, and asynchrony. Clear? Now coming to the picture. Here inspiration, now the expiration. Now expiratory part of the loop is not returning to the starting point. That means there is a definite significant leak is here happening. Okay, and you can also quantitate the leak, the volume leak, how much is actually affecting. So if you are going to almost like it should be 450, but here you are almost losing at 250. So that means it is not reaching to the baseline. Now, if you are getting obstruction also in the flow volume loop, you will be getting reduced peak flow and there would be scooping here. So that means definitely the obstruction is happening, and this is the normal PFT view. So the examiner asks you what would be the normal thing. So normal thing is like this. Now I would be now at the end would be giving you a structure approach to analyze the ventilator graphics. Just remember the steps in the examination. If somebody will be asking you, can you summarize or like analyze in a very structured approach the ventilator graphics? So you can start with like this. Step one, identify the mode and the control variable. Say this first. Examiners would always look for whether it is volume control, whether it is pressure control, pressure support, SIMB mode. Control variables, I have already told how you will be distinguished between volume control or pressure control. In volume control, flow is set, pressure varies. Pressure control, pressure is set, flow varies. And in the Viva, always before analyzing the graphics, you will be saying that I will be identifying the ventilator mode and the control variable. So ventilator mode is, I have already told you, and the control variable is already between volume control or pressure control. Now the second step, the examiner would be showing you the graphic, or in the practical on-site exam or in the online exam like EDIC 1, EDIC 2 or any fellowship exams. So you will be expected to identify the graphic, clearly name whether it is a scalar or a loop, and again in the scalar whether it is pressure time, flow time, volume time, pressure volume loop, flow volume loop. Never jump into the interpretation without naming the graph. The examiner may sometimes feel that you are mocked up by looking at the picture, but you are unable to actually have a structure in your mind. So that is very important. If you start in a structured way, so maybe if it would be difficult also, you would be reaching to the correct conclusion. Are you getting it? Now, step 3 would be analyze the baseline. Look at the starting point of the curve. Is the baseline pressure is equal to PEEP? I have already said you. If it is starting at little bit above, that means it is starting at the PEEP level. So PEEP you have set at 5. Now, does the expiratory flow return to the 0? If no, that means auto PEEP is there. In the flow time, I have shown you, if it is expiratory flow is not reaching with each breath, it is actually going little bit below the baseline. That means there is auto PEEP. So it is not reaching to the baseline. Now, is baseline volume 0? If it is volume, so you will be again saying whether it is 0 or not. So in the exam, if failure of the expiratory flow to reach 0, that would be indicating there is some amount of air trapping. Clear? Now, step 4 would be inspiration. Analyze the inspiration. So you have first identified the mode and the control. Second, the graphic, whether it is a scalar or a loop. Then start from the baseline. Then baseline, from there you will be going inspiration. Now inspiration, you ask 3 questions: the shape, whether it is square, decelerating, scooped, smooth or irregular. I have shown you few of the images that would be guiding you. You will be getting some of the troubleshoots there. Magnitude, in the inspiration you will get the peak inspiratory pressure, the delivered tidal volume, the peak inspiratory flow, depending on whether you are dealing with the flow time or the pressure time or the volume time scalar. Now, coming to the third one is the time. In the time, you will be getting the inspiratory time, I ratio. Clear? Shape, magnitude, time. So, in the Viva, inspiratory limb gives you most important information about the resistance, compliance, and the flow adequacy. Clear? So, now till fourth step, you are all clear? Now, 5 step, after inspiration, you will be analyzing the expiration. Now, in the expiration, you will be asking these 2 questions. Does the expiratory flow return to the 0? That means normal. If it is remaining positive, auto PIP. Maximum, almost 75% questions in any of the exam, the examiner would be revolving around auto PIP. So always don't hesitate to use this if your expiratory flow is not returning to the 0. Now, if there is any expiratory flow limitation, so you will be saying whether you are dealing with premature cycling, sudden cutoff. So here comes the 2 concept, whether it is like the premature cycling or delayed cycling. I have shown you the picture in the third or fourth slide where you are getting the trigger, then the target, and then the cycling. So cycling may be also be the one of the troubleshooting for you. So expiration tells us more than inspiration in the obstructive disease. Inspiration would be more informative for the compliance problem, like ARDS problem. Clear? Now, coming to the step 6, you have to differentiate between resistance versus compliance, because already from the inspiration and the expiratory analysis, you have now got an idea whether the problem is related to the resistance or the compliance. Now, in the examination, again, believe me, plateau pressure they would be expecting from you in very clear and concise manner that would be reflecting the compliance. Peak pressure reflects resistance plus compliance. Peak pressure is never only resistance. If your plateau pressure will be rising, as a result, what would happen? Anyway, your peak pressure would be high, though the resistance component will be same. Are you getting it? So peak pressure is actually combination of the plateau pressure, that is the plateau pressure plus the resistance pressure. So it is never the only resistance. So that is something myth that you will be dispelling at this point of time. Now step 7 would be look for the ventilator patient asynchrony. Till now you are concentrating on the ventilator screen, but at this point of time when you have already analyzed starting from what is the mode, what is the scalar, then what is the baseline, then the inspiration, then the expiration, then the resistance and compliance, you would be looking at the patient. The examiner would not be very happy if we will be only focusing on the ventilator. Like the monitors, we are not treating the monitors, we are treating the patient. So that's why always actively search for whether it is ineffective triggering, double triggering, flow starvation, delayed cycling, or auto triggering. So any mismatch between the patient effort and the ventilator delivery, that would be indicating asynchrony. So these words you have to use if in your examination. Now, step 8, everything you have to integrate with the clinical context. By looking at the patient doesn't solve your problem. So always trying to create one story, whether this was a case of ARDS, then landed up in the pulmonary edema. Now your compliance is poor, patient is not getting the proper oxygenation. Whether the patient is acute exacerbation of COPD, now you are getting the auto PEEP generation, dynamic hyperinflation, hypotension, you need to optimize the PEEP. Whether you need to give sedation to the patient so that the patient will not get the double triggering, whether you need to give some fluid because the PEEP requirement is very high, that is actually affecting your venous return. Whether you need to do the FBG to look at the oxygenation and the ventilation part, whether you need to be ordering this ABG 4th hourly, 8 hourly after doing the maneuver. Whether you need to do some maneuver on the ventilator like inspiratory hold maneuver, expiratory hold maneuver, recruitment. So all these things would be the pet question of the examiner. Like, so always the last line would be ventilator graphics must be interpreted in the clinical context, not in the isolation. Now last one, just integrating doesn't solve your problem. The examiner would be expecting that as a doctor, as a responsible intensivist, as a consultant, you need to suggest the corrective action at that time and do it also. So always the examiner would be expecting you not to only verbalize. Some smart candidates, they can just answer everything, but when they are being asked to do it on the ventilator, they fumble, because you have to be confident to do the corrective action on the screen, on the monitor, and see again, look at the ventilator, do something, then look at the patient. Your movement of the head would propel the examiner that yes, this candidate has worked at the bedside and he has done it, not only advising, and the respiratory therapist or the doctor, senior doctor has done. So examiners love this step. That's why I have kept this word. Examiner love this step by you will be increasing or decreasing the flow, adjusting the PEEP, change the inspiratory time, modifying the trigger sensitivity, maybe from the 40% you are changing to the threshold of 20%, considering changing the mode. If you are not happy with the ventilator with the volume control, you change it to PRVC, you are changing to APRV. So the examiner would be biased that yes, this candidate is excellent. And finally, you can conclude with, based on this waveform, I would adjust the settings to correct the underlying physiology, because it's always the physiology which is speaking on the monitor or screen. So that's why I have kept the quote. It's the patient who is talking, but as the tube is there, it is being relayed through the ventilator screen. And you, as intensivist, as the smart intensivist, you can understand what are the words the patient is trying to whisper. Clear? Now, I am just sharing with you some of the images. Just you can just go through. I know it is almost 3 hours 30 minutes, and I am last. I would say in the cricket, I'm the last batsman waiting for my turn to be there, and I am going through all the lectures. So somehow I feel that you will be over bombarded with so much of information. So that's why I would be now sharing with you the pictures so that just have a visual impression printed in your mind. This is the square flow, clear. This is volume control, descending volume control, flow. Okay, identical flow wave, flow trigger is the pink. This means this is the flow trigger happening here. Decelerating, pressure control, flow. Variable deceleration, you can see the flow trigger here happening, pink. Now this is the normal peak inspiratory flow, this is the decelerating flow, normal inspiratory time constant. Here happening reduced peak inspiratory flow, so there is some amount of resistance happening. Okay, pressure control with decelerating flow, prolonged inspiratory time constant. Now low compliance, you can see here the delayed cycling, short inspiratory time constant. Here prolonged, here short. Clear? One is resistance problem, one is compliance problem. Then the inspiratory effort, the patient is trying to actually take so much of inspiration here, upward shift of the inspiratory curve. Okay, it would look like a little bit of swollen. Now these are the expiratory flow waveforms in volume control ventilation. You see here normal expiratory line, I have already told like this. If prolonged expiratory time, reduced expiratory flow is there, that means high resistance. If there would be low compliance in the flow, you see here increased peak expiratory, short expiratory time here. Clear? Then it would be all in the baseline. Auto PIP generated, I have already told you the flow, the inspiration begins before the expiration is complete. So that means every time there is air trapping. Okay, and that is actually affecting the venous return and the hemodynamics. Now expiratory effort, you can see here expiratory flow moves downwards. I have shown you the inspiratory effort in the inspiratory waveform. That was little bit higher. bit swollen in the last picture. Now expiratory flow moves downward, it would be expiratory effort. Now inspiratory effort, you can see here, failed trigger. This patient is trying to trigger the ventilator, but it is unable to do it. Clear? Now expiratory flow limitation, I have already told it is taking so much of time to reach to the baseline here. Longer expiratory time. If you are getting tracheal secretions, you would get all these irregular oscillations. Okay, this is an excellent article. I would share with you the picture also. Now, coming to the few of the other things the examiner sometimes ask. This is the peak pressure, this is the plateau pressure, this is the PEEP. Now, high resistance, you would get the peak inspiratory pressure to be very high, but normal plateau pressure at the same level like normal. Okay, peak minus plateau is actually very high here. Okay, now low compliance, your plateau pressure is high, but your peak pressure is somehow okay. That means your resistance is not the problem, rather it would be the compliance is the problem. Here, high resistance, low compliance, it would look like this. Okay, now comes there would be a question, because I have been part of like some of these mock test as well as exams, where the examiner would be asking you what is SI, stress index. Now stress index, you have to sometimes draw it. The examiner would expect you what is the normal stress index. It is 0.9 to 1 or 0.95 to 1.05. If you are doing the recruitment, stress index would be less, upward concavity. Now over distension, it would be more than 1.05 over distension, downward concavity. And inspiratory effort, it would be downward concavity. Now, if the examiner would be expecting you to tell 2-3 lines about the ventilator stress index, VSI, what is this? This is the shape of the pressure time curve during volume control ventilation with constant flow. With constant flow, you can see here. Okay, flow would be constant, and you would be getting during the volume control ventilation pressure time. Now, what is the importance of the ventilator stress index? It guides your PEEP management, and again, what would be the tidal volume to prevent the VLI, ventilator induced lung injury. Normal is around 1. This would be linear rise. That means optimal compliance. Normal. Right. This is the normal, like this. Now, if it would be going up, upward concavity, that means less than 0.9. Recruitment, de-recruitment, you have to increase the PEEP. More than 1, downward concavity, that means over distension. That means you have to reduce the volume, tidal volume, or the PEEP. Clear? Okay. Now, this is something pressure waveform volume control and some of the other things that you need to remember. This is the resistance thing I have already told. Compliance thing I have already told. This is the expression with delayed cycle. It should be normally at this point, but it is taking a lot of time here to cycle it. So volume control with descending flow. You can see here, end inspiration is happening after it should have been here. The pressure is increasing here. So that is not a good thing. You have to actually decrease the threshold for the cycling. Now, inspiratory effort, it would be like this. Cardiac oscillation, you will be getting this type of wave in the expiratory. So that is something will be affecting your reverse triggering. So cardiac oscillation is one of the reason for the reverse triggering. Okay, early or reverse trigger. And there is a double trigger, that means no expiration is happening here. Patient is trying to breathe before the expiration is happening again. So you need to be troubleshoot the triggers. This is sometimes a favorite question, but yes, it need to be understood in the real context. Now, the ultimate memory frame for all of you, try to take it as a mental hook. MBIERACC. How you remember, I don't know, but this is something. Mode and the control, I have already told you. Baseline, inspiration, expiration, resistance versus compliance, asynchrony, clinical context, corrective action. If you remember this, nobody in this world can derail you. Just take my words. So I would be maybe at this is the last slide before I would be sharing with you maybe 2 articles. The distinction answer should be, the examiner would be standing with a standing ovation to all of you. The distinction answer, if you are answered this is worth gold. So give it a verbatim. Try to answer in this format. If the examiner expect you to tell in complete sentence, I analyze the ventilator graphics by first assessing patient interaction, identifying the mode and the control variable, naming the graphic, analyzing the baseline, inspiration, expiration, differentiating resistance for the compliance, actively looking for asynchrony, correlating with the clinical context, and finally prioritizing corrective ventilator adjustment to address the underlying physiology. Oof. This is something the examiner would stand up and you will be like thinking that yes, you have got the gold medal. Now, common exam fail points. When you are talking about gold, you should also look at the coal. Okay, describing curves without naming the mode, ignoring expression, missing the basic things like auto pip, some of the standard maneuvers you are not knowing, you are not confident, low link to the patient comfort or the hemodynamics, and you have not discussed anything how you are going to have a corrective action. This is like something the examiner would not take 5 seconds to fail you. Okay. Now, these are the two articles I found very informative and conceptual building. One is the ventilator desynchrony narrative review. This was published in 2020 Annals of Thoracic Medicine. And this is the stepwise ventilator waveform assessment to diagnose pulmonary pathophysiology. This was published in Anesthesiology in July 2022. Now, at the end, if you are still not very sure, you are unable to troubleshoot your patient, and the examiner still expect you to solve the problem, try to enter into the ventilator, maybe using the hammer. If you don't have the hammer, take from the knee hammer from the bedside and try to enter. Thank you for your patient hearing, and I think we have crossed I think the time limit also. So if there would be any questions, I would be happy to answer. I hope the efforts that we have put are worth spending 3.5 hours in the, maybe I would say, the January last week of the 2026. And I hope that the lectures were up to mark. If you feel that there have been some technical glitches, this is completely beyond our capacity, and we all know this can happen with the real exam also. And this has been feedback from the edict 2 candidates also, that there have been some or other the hiccups. But at the end, everything that ends well is what we expect. Thank you very much